Top of the hour. So welcome everybody to today's Research Nexus. We have two more pillars of our community talk to us today. We'll learn a lot. We have Ms. Chandana Pedapati and Dr. Inder Makin join us today to talk about their research regarding ultrasound. And I believe they don't need a lot of reproduction because we all know them, but I'm just going to talk to people who might be new to our community. And I will first start with introducing Chandi, who has a bachelor's degree in electrical engineering from Northern Illinois University and a master's of science in bioengineering from ASU. And she's a research associate with ATSU-SOMA. And Dr. Makin is a professor at ATSU University School of Osteopathic Medicine in Arizona, and also the dental school, ASDO. He's also an adjunct professor with Arizona State University and working in the area of medical ultrasound and other instrumentation-based teaching and research. Over the years, he has been an independent scientist and entrepreneur active in the area of medical technology development. During his assignments in academia and industry, Dr. Makin has developed biomedical research programs at various institutes, taking concepts through feasibility and evolving them into product embodiments. He's a recognized scientist in the field of medical instrumentation and technology, having published more than 25 scientific papers, has been invited as speaker and chaired various national and international conferences, and has 65 plus allowed and issued patents, filed more than 100. And he has had a medical degree from India, engineering degree from Germany, and his PhD in biomedical engineering from UT Austin, with specialization in nonlinear and medical acoustics. He's also an accredited medical sonographer. So with that, I will ask the speakers to take away.
Okay, hi, my name is Chandi, and can't hear me, just let me know. So let me share my screen. Okay, can you see my screen okay? Yes. Okay, all right, so today I'm just going to talk a little bit about the projects that we've been doing in the SOMA lab in integrating bioinstrumentation into medical education as well as other research initiatives. So I'm just going to talk about three projects that we've been having ongoing. One of them is experiential medical education. One is a median nerve carpal tunnel study in the dental practitioners. And the third one is assessing myofascial trigger point response to osteopathic manipulative treatment. So first we'll talk about the osteopathic principles and practices lab. So traditionally, there's a craft model where the instructor or preceptor is demonstrating the manipulation and the students will observe and do a peer-to-peer practice. In our experiential model that we've developed, we have the preceptor and we have bioinstrumentation, and the students themselves are conducting they also get the demonstration as in the craft model, but then we add the bioinstrumentation. So the students are observing real-time feedback of biophysical signals to assess whether or not their manipulations are working. And so funding for this, we had AACOM Research Grant, John C. Lincoln Foundation, and also ATSU internal support. So just to give an idea of the experiential learning lab flow that we've developed over the years, there's three components. There's a self-learning component, critical analysis, and then synthesis. So in the self-learning, students will be reviewing their preparatory material and then complete a mandatory pre-lab quiz. This is all done on Canvas. And along with those are demo videos, didactics, and other reading that they can learn. So they come to lab prepared and ready to do the lab that we have prepared for them. And so in the critical analysis portion, they'll do the peer-to-peer OMT instruction and real-time biosignal acquisition. And then with that, we will assist them with the data analysis and then have some critical thinking questions so they can really understand what happened. And then finally, In the final portion, we'll have a large group discussion where we'll really discuss the clinical relevance of OMT using all of the data that we observed. So here's one lab that we perform. This is the muscle performance lab, and we have the grip sensor, transducer, and then we have the electromyograph, 3-lead, and we look at the force and the EMG signals. And we have the students measure the hand grip test before and after osteopathic manipulation. And then we give them these metrics to measure. So the maximum force, mean force, time to fatigue, and the amplitude of the EMG signal. In the second lab, we have a cardiovascular response that they're measuring. So they're basically monitoring heart rate and their finger blood volume using a PPG signal. And so they're just taking simple measurements, heart rate and blood volume. And this lab is slightly different. We're measuring the data continuously during rest and then during an inspiratory gasp where you just hold your breath, and then during OMT, and then during another final rest. And so they can see how these signals are actually changing during these different manipulations or interventions. And so we've done a 5-year retrospective over the labs from 2014 to 2018. So there's 20 individual lab dates. So we do 2 in the fall and 2 in the spring. And we take the students of a class size of 160 and divide them into groups of 3 to 5. So we have 582 lab groups of data to look at. And then they also completed a voluntary satisfaction survey. And the study was IRB exempt because it was part of their curriculum. And overall, for the muscle performance lab, the most prominent result that we see is that the fatigue time increased for majority of the students in their observations. Not a whole lot of change in the grip force. And then for the cardiovascular facilitatory response lab, then the main responses that we see is that there's not an increase in heart rate. And then whether it decreases or there's no change, that's a little bit variable. And then as far as the blood volume, there's some response. There's not a lot of students saw no response. And so some of the reasons why the students don't see the expected, so the desired changes for the cardiovascular responses, we expect that with an OAC2 decompression, that the heart rate should decrease and that the finger blood volume should increase. So we have to keep in mind that these students are relatively healthy. They already have very low resting heart rates, so there's not a lot of room for improvement. And also they've been in 2 other OPP labs prior to coming to our lab sometimes, so they're rotating. So they've already been manipulated quite a bit. So we won't see a lot of response, but we do see these prominent results that we can discuss afterwards. Muscle performance lab can really lead into a really rich discussion on fiber types that are being impacted by OMT. And with the cardiovascular facilitatory response, we have a rich discussion on how OMT can really impact the autonomic regulation. And so students have given us their surveys, and this is the combined surveys results over all the labs. And you can see that we ask about clinical applicability, how did the faculty perform, how is the lab organized, is the instrument easy to use, is the material we provide to prepare adequate, do they have enough time to practice, and then how is the overall presentation for the whole lab. And so you can see just a humble brag and pat on the back. The faculty scored pretty well here. And then overall, the time allowed to practice is what usually scores a lot more variance in the time allowed to practice. So in order to meet this need, there's quite a lot of comments actually early on when we started the labs that they wanted more time to practice. So once we started doing the demo videos and the preparation material on Canvas, we found that the students are coming to lab much more prepared. They know what to expect, and they're actually more familiar with how to use the instrumentation, so the labs run quite more smoothly. And then we have quite a lot more time to actually have a discussion about what's going on. So the comments we get from students, I've just put 3 here, but this kind of really summarizes what students take away from this type of teaching method. This was a very valuable lab because it gave me more confidence in my OMT applications. So students are feeling more confident with how they're actually performing their OMT. I was able to see immediate benefit of subject progress after simple OMT. So this really speaks to the clinical relevance of OMT and how their manipulations might serve other populations that are symptomatic. And then I hope to do a research project comparing OMT to control. So because they're using research instrumentation, it's giving them a lot of ideas as to how they could go forward in doing their own research. And so these are all really promising things that we can encourage our students to do. And they in fact do, like, we have done some research projects with them. And so a couple of modifications we tried in these labs over the years. We tried a wireless setup with BioPack bioinformatics, and we found that there was no improvement in the student experience, ease of use, or it also did not help with their understanding of clinical relevance of OMT. So it was a nice to have, but it wasn't necessary. We also tried Turning Point, which were these, I don't know if everybody uses these, but they're little clickers that allow students to give real-time feedback. So we could look at the large group cumulative results right after the lab was over. And what was interesting was that the large group cumulative Turning Point results did not always match the worksheets. So I think there was a little bit of a group think where if other people were raising their hand that they saw an increase, then they felt that they should too. So that was interesting. But the final modification we made that has been really fruitful for us was including this peripheral arterial disease unit. So the BioPack that I showed previously was a research-only unit. So this one is a clinical device, and it's used for screening peripheral arterial disease. And what we were allowed to do, the manufacturer allowed us to tap into the unit to collect data long-term. And what that means is then we could create our own interfaces, and we could actually that data and then use it in the same way that we were doing before. So what we did was we applied it to a lower extremity flow. So in the fall, the cardiovascular response was for upper extremity. So now we did lower extremity in the spring. And in order to develop this, we collaborated with ASU Biomedical Engineering Master's students. And so we had 3 students that worked on this over the years and developed this further. We were able to then apply this in our OPP lab, for the lower extremity. And then finally, because this is a clinical device, we can use it in a clinical study. So we had a couple of students at Chicago CHC, and they were able to actually do some studies with that. And then we presented these posters at AIUM and ASHA Congress. Now I'll talk about this study. And I forgot to mention, if anybody has questions along the way, go ahead and ask me as we're going. So this is a study that highlights our interdepartmental and interinstitutional work. We worked with School of ASHES, the School of Health Sciences, Dentistry, and SOMA. And what we did with this study was we imaged the carpal tunnel in different regions, looking at the median nerve. And the median nerve was basically, we're looking for early signs of carpal tunnel symptom in dental practitioners. And we were also able to utilize this special tool function that allowed us to look at the blood flow inside the median nerve. So in order to look at slow flow inside of a nerve, you need high frequency ultrasound. So we were able to obtain a high frequency ultrasound probe and use a Q analysis, which was a quantitative view of looking at blood flow. And what we found in the study was that the practitioners actually had higher than normal values for median nerve size, and they actually had elevated blood flow. And so we concluded that dental practitioners, I should mention, dental practitioners were not diagnosed with carpal tunnel symptoms. They were considered normal. But because their values the metrics were elevated, that we concluded that the dental practitioners represent a unique subgroup who are at risk for these work-related carpal tunnel symptoms, or perhaps they need their own normative values since they're using their hands for fine motor skills more. And then the final, interdepartmental collaboration, and this manuscript is currently in review right now. And the final project I'll discuss this is actually part of my dissertation work at ASU. We're assessing myofascial trigger point response to osteopathic manipulation. So the purpose of this project was not really the assessment, understanding the treatment. It was really developing a toolkit where we could then measure musculoskeletal tissue, specifically with myofascial trigger point. And so we focused this study on the forearm. And you can see this is our setup here, and here's the ultrasound. And this is an inter-institutional collaboration with University SOMA, obviously, and then University of Cincinnati, as well as ASU. So first we had to understand myofascial trigger point pathology, and so there's a great amount of consensus in literature that MTP is characterized by painful palpable nodules and top band of tissue, ischemic condition, so low blood flow, and altered muscle function. So our approach to measuring the myofascial trigger point tissue was 4 different parameters, and we measured these parameters with different modalities. So the first one to measure was the pain at the myofascial trigger point site with a pressure algometer, and this is a validated tool. And then we measured tissue elasticity for the top end of tissue and regional blood flow with elastography and power Doppler sound. These are ultrasound modalities that we had to develop. And then the muscle activity, we used the similar to the BioPack labs and the student labs, we used that same setup. And so this is just a quick video to show what strain elastography actually is. So ultrasound is put on the tissue and then it's manually moved up and down so you can see how the strain in the tissue changes. And so you can see where there's soft areas and hard areas. And so what we did for our study was we developed this setup here. So this is a motorized arm and it's held in place with this grip. And then right here, we created a uniform force distribution so we could have a uniform tissue compression. So here's what that looks like. So you can see it's moving here and you can get the corresponding elastogram in the back. And then I added to this a force sensor. While the tissue is being moved, we can measure the resistance of the tissue to that compression. And this is what it looks like in a relaxed tissue. So you can see there's not a lot of resistance. And in a contracted tissue, you can see that there's much more resistance. And so I used this measure to actually calibrate the strain map because the strain map is a relative value. So we wanted a quasi-quantitative map. And so this is what that looks like in a relaxed and contracted forearm. So the yellows represent softer tissues and the blues represent hard tissues. So you can see in the relaxed tissue, there's a lot more yellows or softer tissues, and in the contracted muscles, there's a lot more darker values. We also looked at blood flow with ultrasound, and normally when you're using power Doppler ultrasound, you're really interested in just the highest values in the peak systole frame. So what I did different here was I used a time series estimate. So I took over a second of data to look at the entire cardiovascular cycle. And what we saw here was that this here shows you the power Doppler intensity, so all the color range from 0 to 60, and how many pixels in the frame. And what you can see in the forearm at rest versus the forearm after light exercise, that there are increases in the higher pixel intensities, but there's a huge amount of change in the lower intensity values. And the lower intensity values correspond to slower flow and reverse flow. And we really want to know about these subtle changes because with osteopathic manipulation, there may be very subtle changes, but they may be important and quantifiable. And so that's kind of where I focused that regional blood flow estimate. So we did a pilot study. We compared osteopathic manipulation with rest and with exercise in a pre-post test. So we compared pre-rest, post-rest, and so on. And significant results we found were that the pain pressure threshold increased significantly for the OMT group compared to rest and exercise, and that the superficial tissue compliance improved with rest and OMT. The other two values, we didn't see a lot of change. So this is ongoing work. This study has served as pilot data for grant proposals. And I think Dr. Markin is still working on one that he's submitting soon. And then I'll be presenting this in full at in Kirksville, the symposium in Kirksville this year. And that's all I have. So thank you. Anybody has any questions? I'm happy to answer.
Yeah, questions are welcome. Yeah, it's just I would add, again, presentations are great. Everything looks very nicely tied up in a beautiful bow. There's a lot of instrumentation that has been developed. A lot of thought has gone here. A lot of heartache and pain, and we're not even started, right? We're just slow. Yeah.
I have a question. Thank you, Chandi, for that presentation. If you had your ability to do anything, what would be your next steps that you would like to do?
That's a good question, Dr. Vadia. So like Dr. Makin said, there's a lot of instrumentation. So for myself, I see a lot of areas of improvement in just the instrumentation side that we can improve upon. Also, carrying forward another study, I would do a lot of things differently because I learned a lot after running the pilot study. So, and I think I've learned a lot more about just how to measure tissue, myofascial trigger points, pathology. So yeah, I'd measure things differently. I would do things a little bit differently. Yeah. And I'd be excited to look more into that.
Thank you. Thank you.
I had a question, Chandi. What was the rationale behind introducing an exercise group as one of the comparators?
So we wanted to have a positive control, and sham is a challenging thing to do with OMT, especially like in the forum, because like the patient can see it, the doctor can see it. It's really challenging. So I know that with previous just practicing with ultrasound, I know that I can increase the blood flow temporarily, at least with the light exercise. We just had them grip the bulb at least 40 times. So that influences just getting the blood flow moving. So that shows a positive control. That's a physiologic response. Whereas rest, they're not doing anything.
Down the road, would you consider introducing a pharmacologic group maybe?
That's a good question for my co-investigators as well. I did not pick, I actually had part of my inclusion criteria to not include like people who had used any pain medication, because I don't know how that would affect their response to exercise or rest, as well as what would OMT do to somebody who's already on pain medications, because we were measuring the pain pressure thresholds.
Thanks for the presentation, Chandi.
Thank you.
It was wonderful.
Thanks.
Hi, nice presentation, Chandi.
Thank you.
So great to hear the highlights, and I know it's been a long haul and
Yeah.
a lot of iterations. So, kudos to the team. So question is, as you're talking about the forearm and you're talking about those trigger points, dry needling or acupuncture has been one of the modalities that's also affected change because of the fascia. Has there been any consideration for being able to pursue that route and have maybe an intervention comparison that's been studied?
Yeah, so I guess when I was reading about myofascial trigger point pathology, as well as treatments, that dry needle came up a lot, acupuncture came up a lot. So yeah, you're right on track. And so for my focus was really just developing a toolkit so that we can now do those studies. And so I just want to validate that. Can we measure? Are we detecting changes? What are we seeing? So now, once we get that nice and tight, then yes, let's definitely do those kinds of studies.
Great.
If I may just add, so Deborah, so this all came from you, okay? So the whole thing is tied to osteopathic medicine and osteopathic evidence for osteopathic medicine. A lot of things that we are doing today, and the reason for people like me and Chandi being around, is through the osteopathic channel, okay? And the second thing is the IRB. We want to be friends with IRB. Any form of interventions make them very nervous, including, as you know, you and I know, and Chandi knows very well, including, needle EMGs and all that. So we skirt away from caspicin and all those fun things. Acupuncture, sure, again, same issues. I think the strength here in the school is within what we are named as, and you know, everyone knows I'm not an osteopathic physician. Neither is Chandi, but we have to go with what we know can be proved, you know, and that's what we are working on. So that's my side of the story here.
Well, lovely. I mean, that's music to my ears as well for the osteopathic emphasis, what we know, and we do it best here. So that's great. And I want to say, though, how it couldn't be done alone. And that's really where we are interdependent on this team, but also on other professionals that we've been able to work with at ATSU. So I think that's important takeaway also, is that this has really been collaborative. So thank you for that acknowledgement. And yet we remember where I started years ago, 15 years ago, and yet the instrumentation has been able to evolve, and you've been able to actually harness it, develop it, and that is bioengineering at its greatest form. So great job. It's exciting.
Okay, thank you. So I'll just give you a bigger, broader brush of what we are about. And, you know, this presentation is recorded, so anyone else can see it later also. I thought it was a good opportunity to kind of give this bigger picture here, you know. So interdisciplinary research at ATSU-SOMA, okay. So let's back up, and this is how I do work, or we do work, is that, you know, the approach is you've got this ATSU as a school with 6 schools, and everyone bemoans silos and things like that. But at the end of the day, we have people, we have know-how, and we have resources. We have to learn how to use them, right? And so that's kind of how we have worked. You've got your own school, you've got other institutions, you've got the professional community, and you've got the corporate world. And I think we've you know, that's how we've managed to kind of work through a lot of the things that you see. You know, Chandi gave you an example of a couple of projects, but I'll kind of follow through on some more examples. So one more time, we've got people, know-how, resources, and then you have this whole, you know, ecosystem, and you create, you know, your own, you know, hybrid in it. So, but at the end of the day, you know, our salary comes from the school. So we've got to do a fair amount of research, fair amount of teaching, because without teaching, the school doesn't really exist. And we recognize that, you know, Chandi, myself, Deborah Heath, and everyone else, teaching is our bread and butter. We have to do that. And so research follows out of that teaching. And then last but not least, you know, we talk about collaboration. How about training? So we do a fair amount of training, we meaning myself and colleagues of mine, you know, for faculty, students, go out in the community. So this is kind of our activity right now. I'm going to put together here, you know, a short list of people who are involved. And if I have missed anyone, please, I will buy you lunch. But, you know, you have to go out to the real world in your environment and work with people. All these, Deborah Heath, like I mentioned, Deborah and I and Chandi and some of the earlier students who came from ASU, we did the basic instrumentation based on what the clinician needed at that time, Dr. Heath. Shao, Jim Keane, Christina Weaver, Kurt Bay, and you can see this list. And then some of these are, you know, from the dental school, and then Tammy Rowling, Vineet Singh, Brian Dagenhart, anyone that and everyone we could collaborate with, and there was a reason to do so. We did so, okay, over the past. I'm giving you a 10 years perspective. And I must add, you know, the color choice is mine, of course. Without a research infrastructure, you can't do anything. And so our infrastructure is basically one key person, okay? And the rest is beg, borrow, and steal. So that's where we are right now. just to give you an idea of what some of the stuff that Chandi's presented and some of the stuff that I work on, I've gone and collaborated with TGen North, University of Cincinnati, Northwestern. You can name these. A lot of corporate partners, some from the dental school, some from the medical side, ultrasound side. And in terms of teaching, we have always collaborated. We have, rather than compete with Midwestern, we have written a grant with them, gotten the core funding that got us started with the ultrasound and medical education program. Midwestern, of course, touts their program over a 4-year period. They have a continuing education. Well, we actually, talk the talk and walk the walk, between Dr. Beaver, myself, and others. So anyway, we characterize, teaching as a collaborative opportunity. Work with ASU, done so. We've got about 12, depending on how we count, 10 to 15, a master's thesis coming out of our school in ASU bioengineering. We've collaborated with 2 sonography programs that are local, and I'll give you some examples of that, and training the faculty and students. Okay. So this is the second piece, of activity. So areas of activity, very quickly, I'll run through a very short list. Ultrasound research, that is our core skill set from the bioengineering side. Bioinstrumentation and research, you've seen an example or two from Chandi. Long-term data acquisition, signal processing, instrumentation, and you name it. And some of that has spilled over into the dental school project. Innovations in teaching. I think we are, Dr. Heath or Obadia can correct me, I think we are one of the only program that has an OPP in osteopathic principles and practice. We have instrumentation built in. We published that stuff also, and we hope to publish more. Innovations in teaching in terms of ultrasound in medical education. Dental instrumentation, we've developed quite a bit of new things. I'll talk a little bit more about it. Microbiomic research, it's basically working with TGen, looking at periodontal bacteria as before and after treatment with scaling and root cleaning. And that's a bear of a project. It's still got to be published, but we've got several abstracts out in international and national meetings. Role of lasers in periodontal disease, teaching and training the community, and intellectual property. We've got 2 issued patents, 2 are still in play. And I must say that Research and Grants Office is funding all that. We couldn't be doing any of that without them. So anyway, so that's my plug to research. Is great to say, well, how is research today? Well, research is not a fuzzball, I always say. It really needs money. So, these are some of our sources, research and grants, ATSU strategic funds. We've gotten, Dr. Heath and myself has gotten a couple of strategic fund, programs funded, and so on, also with the dental program. Institutional funding, foundational funding, the Honor Health program, basically foundation, John C. Lincoln. They were the ones who got us started in ultrasound and medical education. Dr. Heath coined the medical ultrasound for DOs, and we got about $350,000. So overall, we've had about $1.5 million invested over the past 10 years, with some of my, hands in all this funding, just for the record, okay? So let me just give you an example. So this is an example of ultrasound and medical education. This was started in about 2016, right when technology was ripe for ultrasound to be used for teaching. And what we did, our approach was really more a synergistic approach rather than, butt heads with curricular committee and all those things that ultrasound has to be there. Rather, we had a consensus-based approach. We inserted ourselves within the curriculum. Where is the need? I know that Dr. Badia and Heath, they led us into OPP and med skills, and anatomy did the same. And program funding, we talked about it. And we bootstrapped, rather than bemoan resources and lack thereof or time. we just bootstrapped whatever we had. We trained ourselves. I'm a trained sonographer, but I didn't know how to do ultrasound to teach. We just bootstrapped. Chandana Pedapati learned how to scan human subjects, and Dr. Bliven and others, were the key people, We got an agreement, an MOU with the local sonography program to get in sonographers here. And teaching content was developed in-house as well as with experts from outside. And then, of course, Dr. Weaver came on board, and then that just boosted the whole thing, several notches, So a lot of our content now is a hybrid of these two sources. Integration was into anatomy, osteopathic medical skills, osteopathic principles and medical skills. So we've got about 6 years of experience. We are an interdisciplinary effort. We still are at the end of the day, we still are interdisciplinary. You call it interprofessional education, call it interdisciplinary, whatever gets us cooking is what matters to me, And we have a lot of faculty and student feedback. This is how we do today. This is how a lab or an instruction content, between Dr. Weaver and myself, we provide preparatory material for self-learning. We come prepared, the students come prepared and respond to content-related quiz questions. We have an introductory lecture, and then we do peer-to-peer scanning. So we don't just tell them, go do scan, it's not right. It's not fair on their time and our time. And then preceptors check up. I mean, I would say, to Dr. Weaver's credit, a lot of this, rigor has come through that. But here is on the left-hand side, you've got clinical application, you've got a small groups, you've got critical thinking, and you've got interdisciplinary approach. And each of these labs or activities are curated for what our clinical or teaching goals are. This is where we are right now. So I'm kind of giving you a before after kind of story, the evolution of how we introduced medical skills based ultrasound. So here is a lab. This is actually tissue phantoms that we prepare in, and we put foreign bodies in there. There's Dr. Weaver, there's Dr. Allgood over here. So internal bootstrapping, internal resources really gets us started. And then, students scan. There is a scripted scanning. There's a scripted evaluation on site and a checkoff from faculty or preceptors. But, they have a lot of fun. But then they are tested at the end. They have to have the skill sets that take them to the next level so that they know what they learned and we know what they learned, So that's kind of research in medical education that we are practicing on a daily basis. Of course, we have, the feedback like Chandi described. So this is very early on. And we if you look at imaging, relevance of imaging and greater use of ultrasound in the curriculum, students knew what they wanted. On a 5-point scale, you can see over here, that you're basically, I never got these kind of grades of my own, in any courses I took, So this is great to see that our output, coming from what we teach. And, you can look at these strong points and comments on the lab. Students recognized that they wanted more and more clinical exposure, and they saw the value of what we were doing. And same applied, by the way, to the bioinstrumentation stuff that we do. They see the clinical relevance, and it's not just a GBiz, we can use this technology. Okay. So let me just switch gears, and here is another project tied to imaging. My goal is to use ultrasound as a tool for research, as a tool for teaching. So this is a project that Tammy Rowling from PT, this is part of her PhD dissertation, by the way, where she was looking at diastasis. So rather than let me jump here. So this is the anterior abdominal wall, and here are the rectus abdomini. And this linea alba over here, it becomes stretched from pregnancy, from crunching, from weightlifting, old age, obesity like me. This becomes wide like this. So if it is more than 2 centimeters, then there's this this condition called diastasis rectus abdominis. And we did a 50 subject study, women and men. And we basically scanned with ultrasound. We have high resolution ultrasound capabilities, and we have a number of projects in this field. This is just an example. And we scanned and we looked at ultrasound, based results. And here are some of the results, the risk factors. But let me just cut through the chase, and this is what we did. So basically, if you're looking at skin, subcutaneous tissue, this is the subcutaneous tissue. Here are the rectus abdomini muscles. So you're scanning like this. Look at this footprint over here in the middle of this body. And you're scanning, you're looking at this bow tie, which is the rectus abdomini muscles. And this is the linea alba. And we measured this at 6 locations along the anterior abdominal wall and along the midline, above umbilicus and below umbilicus. And we looked at the trends of this linea alba's distance and as well as this muscle structure. So basically, this is a research project that was presented at AIUM and so on and so forth. It was part of a PhD. And here are kind of the results out of that, rather than go through 1,200 images. What we found was that, out of the population we scanned, we had 57. This is just a coincidence, this is like a lotto number. But bottom line is that 57% of people scanned had DRA, okay? That is, distance was more than 2 centimeters. 57% were males. So, that was quite a surprise, and a lot of factors come in there. Age, obesity, and, earlier hernia kind of tendencies, and so on and so forth. But also weightlifting. A lot of sportslers had this DRA that they were not aware of. And then, anyway, we did this study. It's still to be published in a paper. One day it will be, but we have the data, we have assessed it. And this is the kind of research we do. So that was kind of the goal here. So I'm going to switch gears here and just tell you, where is the sausage made? We don't do it, at our homes. So we have a lab, believe it or not, in building 5845. A lot of work went into getting this space and maintaining this space. This is in a clean space, so state. Right now, it doesn't look this clean. It needs to be cleaned up. But this is the space that we have. This is within the interdisciplinary research lab, and we collaborate with other groups in this area, in this lab space as well as in the larger lab space. So let me just switch gears on here and tell you that I'm sitting in this lab, which is in ASDO. And very quickly, I'm looking at working with different colleagues over here, laser applications in dentistry, use of ultrasound in assessing soft tissue anatomy, assessing TMJ, design of instrumentation for orthodontics and other things, bioinstrumentation applications. But these have been colleagues from whom I have learned a lot, and we have done a lot of work together. And then, needless to say, people like Chandana Pedapati and others who are bioinstrumentation oriented people have helped out in these projects. So I'll give you a couple of very quick examples. But resources, faculty, collaboration, interdisciplinary team, space, and equipment. Without this, none of these things are possible. Otherwise it's just a nice PowerPoint, which is not good enough, okay? Anne and I and Dr. Schlossman and others, we got, this internal grant, which allowed us to then actually build this lab. Part of the money went into building this lab. Part of the money spent on building this lab was from this internal strategic grant, which was a competitive grant. And this allows it on the Mesa campus, the only place where we can do wet lab studies within limits, of course. We are not going to, start here getting canine studies and all going. Dr. Spolarich is listening, so I'm just telling it for the record. That's not my plan. But anyway, we have equipment over here. This is an equipped lab, and it allows us to do things that we couldn't do before. It's an amazing thing. We have an interdisciplinary lab, and we have this lab, and we have collaborating partners. And here are some lists of, our bragging things, that we can use this lab for, So here's an example of an ultrasound-based study where the question is, this was with Dr. Rich Cohen and some students over here in the dental school. But the idea is temporomandibular derangement, joint derangement is an treatment modalities, among others, are physical medicine, osteopathic treatment, and so on and so forth. And Dr. Cohen is a pain specialist, and he wanted to know what this TMJ looks like. And here are the two planes that I set up imaging capabilities for. And this is how a temporomandibular derangement looks. And I don't know if you can hear the audio, but I'll let it run one more time. So this is basically a cadaver model that shows derangement. So if you put an ultrasound, high resolution ultrasound imaging transducer over here on the TMJ, and you have the patient or subject move his or her joint, this is how you see the throw of that joint and the disc, the temporomandibular disc. Okay. And so the key here is that, that this is a live subject. So you can do this chair side. You can study this anatomy for so many different reasons. Okay. So this is a study, again, a 25, 30 subject study that has been presented at a couple of meetings. And we are hoping to, write this paper up because it's a completed study. So, so that's pretty much to this. Another near and dear to me is a study that is tied to root canal treatments, and nobody likes root canal treatments done on them. But anyway, bottom line is that if you put, what they do is they put a whole bunch of very poisonous stuff as sodium hypochlorite in here. And that hypochlorite actually can kill, it's kind of, napalms it, the root canal bugs. Problem is that if it drips out and if it is extruded out, that fluid out of the apex, then what happens then? Then you have a patient with a lot of problems because that toxic substance has gone into soft tissue and into the maxillary tissue or wherever that apex is looking at. Okay, so what the question to me was from the ASDO people was, well, how can we look at this and understand what the flow parameters are? What happens when we make these we make these cavities? What kind of stuff gets extruded out? So extrusion here, just to give you an idea, is on the order of 1 milliliter per minute. So 1 teaspoon is 5 milliliters. So you sit here and you have, this is an artificial tooth, a plastic tooth, and I'll just run this video for you. And we developed this computer control system from internal development. And you can see this fluid as you can monitor the pressure in this line, as well as this fluid coming out. And you're measuring that flow. You're measuring it on a microbalance. And so if you have a stopwatch and you have the weight, then you have the flow rate, right? So we are looking at different teeth, different cavities, and how the flow rate changes. So this instrumentation allows us, it's a test bed for any kind of teeth that we can, test different cavities. We've got some simulations, numerical simulations for what the flow is. Is it turbulent flow? Is it uniform flow, etc.? But anyway, I don't want to bore you too much about this, but this is the kind of work we do on a daily basis, okay? So what is it now? So I want to go back to the first slide. So innovations in teaching and research, this is what we do, is that what I think about research, I think about, building this infrastructure, getting the funding. And the output is, of course, papers published and results and scientific, learnings. We've got a fair amount of each one of these, and I don't want to, name numbers over here or so on and so forth. The same thing is innovations in teaching. And we've given you some examples use of, innovative means for teaching students medical skills, learning more, and among other things, we're we're kind of mentoring some of the medical students also to do research projects with us. Chandi's highlighted some of those, and some are ongoing. We just don't have enough time or capability in terms of manpower. And then last but not least, training faculty, students, community. And this goes both into SOMA and ASDO and ASHES and so on and so forth. So I just wanted to close with this, and just to wrap up, this harebrained ride I took you through, multiple projects. And at the end of the day, my take is I'm happy in the lab and I love to teach. That's what I do. And, we have people collaborating, partners over here with whom we can work. And that's the beauty of this whole thing. So that's about it. Okay. Any questions? I'm here, and you can ask me now or later or whenever.
Well, if the audience doesn't have any question, I have one. Do you see any opportunities for different interdisciplinary like the students to work on interdisciplinary projects?
Most of these projects have students either from ASDO. ASDO has a research program. So students are allowed to do 6 weeks worth of research. And Dr. Svolarich and Schlossman and others are very, very smart about how they can divvy up this work, because nothing gets accomplished in 6 weeks. I mean, if somebody untrained comes into the kitchen and says, let me help you, it doesn't work that way. You have to teach them, stretch that out. And so that's how we are using students. I personally, with Chandi's help and Dr. Heath and others, we do mentor students within medical school. We've got a list of those. I think the learning there is very slow because they have to. Their academics are the first. If they don't have academics, we don't take them on. We do not waste their time. A fair amount of the project that Chandi described with carpal tunnel ligament, we had ASHES student in there. The project that a similar project to the diastasis, for anterior abdominal wall, we had medical students in 2018, 2019. I did a whole study on looking at subcutaneous tissue distribution with ultrasound. It was a funded research, and I had medical students come in, So yes, it is really, as far as I'm concerned, anyone who has skills and interest can come in, as long as they don't blow their, grades out of the water, So we are very, very picky about it because I don't want to be disruptive. We don't want to be disruptive, They have a lot to do in their academia. Does that answer your question? Yeah.
Yes, absolutely.
Yeah.
Baby steps.
Yeah.
One of the things I always appreciate for all of the people I know on this call is how willing you are to embrace the students in their interests, and that really shows in your presentation and in what you just said as well. But I also see it year after year for, as I said, everybody on this call that I know personally. I've seen it.
Yeah. And I mean, to be selfish here on the SOMA side, it's the reality now with this pass fail, we keep talking about that, and the students are interested in doing research. We are here to foster that, and it's just you've got to bring in time and resource, and it has to be. It doesn't have to be money necessarily. It's time and resource. I mean, there's so many things to discuss. I mean, we have an ultrasound interest group that I'm running, and we invite speakers from outside. We do all kinds of things, but I mean, there can be more, built out of that if needed. As needed.
I just want to respond to that as well, that question. So I am sort of the interdisciplinary person here because I'm not an osteopath, and I'm not formally a researcher either, so I just wanted to thank Dr. Heath and Dr. Makin and so on for just giving me a chance to even be a part of this. So yeah, that.
No, you've earned it, so you don't have to be thankful
Well, I
about
gotta
anything.
give credit where credit is due. So
Okay, but appreciate everyone's help. I mean, really, thank you so much. Yeah, and thanks for the opportunity to present this. Yeah.
Well, thank you, Dr. Makin and Chandi, for your valuable insights and giving us more things to munch on. Hopeful for a better future of research.